Hello students. I am recording, believe it or not, this lecture for maybe about the third or fourth time. I had a clinical day today, I had a clinical day yesterday, so I'm exhausted, but I'm going to do this because I promised that you would get an audio lecture, and of course you need to have an audio lecture before your exam on Monday. So this will come in three parts. It'll be where I will touch on the highlights of substance use disorder. I will touch on the highlights of abuse, paraphilias, and assault in a separate recording. And then the third recording is to give you perspective of what's going to be on your unit exam on Monday. The anticipated time for you to spend with all of this is roughly about 3 hours. Now, to catch you up with what we've talked about, and we left off talking about opioid dependency, and I think I almost finished that, but I'm going to hit the highlights of two key things that are important. Number one, there's a difference between alcohol withdrawal and alcohol withdrawal delirium. Even in your textbook, it talks about mild, moderate, severe signs of withdrawal. What you need to keep in mind that's most consistent is the early times that you will see the signs of withdrawal is in between 6 to 12 hours after the last drink that you can expect to see withdrawal signs. In this particular slide, it gets a little bit confusing because it's going from earlier signs to now more advanced signs. It also depends on the amount of alcohol consumption that the person has achieved over a period of time that denotes the severity of the withdrawal. And so nurses have to stay on top of minimizing the withdrawal symptoms for everything that we talked about. So we can expect to see delirium tremens, which is more of psychotic type symptoms, hallucinations, illusions, visual hallucinations in particular. So think about that. And so that you can expect to see, where you have this slide peaks in 2 to 3 days, but you can see it between 24 and 72 hours after the last drink. So if you notice this, it becomes a little bit more serious with fever and everything in that alcohol withdrawal delirium. Same thing as DTs. We talked about treatment. We talked about management. I have no idea why this is moving very fast, but anyway, it did stop. So when we talk about substance abuse and opioid dependency, then we mentioned that, and the key thing to consider here is immediate effects and withdrawal effects. And so I'm only going to give you the highlights of immediate effects is under the influence. Also, one key thing to think about when you're thinking about substance use and the immediate effects versus the withdrawal effect, there is a difference between central nervous system stimulants versus central nervous system depressants. So if they are central nervous system depressants, which is opiates and alcohol, they depress the central nervous system, so everything is sluggish. Even vital signs have decreased in thinking about that. If it was a stimulant, of course, we're talking about excitation, and in the immediate effects, there is more tachycardia, high blood pressure, more anxiety, those types of things. So think about it in that. So getting back to the immediate effects, key things to consider that I talked about in class, pinpoint pupils. The person's going to feel euphoric. There's going to be apathy. I don't care. Their pain will be well in control. There'll be nodding off. In the withdrawal phase, though, then you're going to see dilated pupils. You're going to hear some runny nose. They're going to be classic yawning. Those are key things: yawning, dilated pupils, more, insomnia, more joint pain, hypertension, restlessness type thing. So think about flu-like symptoms, rhinitis you may see, or cold-like symptoms in the withdrawal phase. We talked about clonidine. You have another slide for that. And then methadone as well can help to minimize the withdrawal. Phase 1 is considered euphoria or rush. Phase 2 is a sense of well-being or high. Phase 3, and this is opioid, it's like a not offering escape from reality. Where phase 4 usually is withdrawal. You don't need to think about it in the context of withdrawal, but I do want you to think about it in the context of you know so you do need to think about it in the context, though, of like with the medication used to treat it. And again, psychopharmacology, treatment of opioid addiction. We mentioned these things in class too, so I'm going to give you a sense of reading that. And I think I think I talked about this, so I'm not going to belabor that, but I would make sure that you focus on clonidine, which is a non-opioid suppressor to minimize the withdrawal, and methadone. We talked about it as needed for getting people out of the drug culture, getting people from IV drug needles and sharing and HIV infections, those type of things. So get them out of those risky type situations that could be problematic. And there are all sorts of things. We already talked about national epidemic. We talked about, how they're doing things a little bit different with it, prescribing Narcan for the opioid dependent persons, so to keep them from overdosing. We talked about picking up needles in emergency room situations, and so everything is a little bit different in terms of understanding that now addiction is a disease. So buprenorphine, Suboxone, that comes with 4-part buprenorphine, 1 part naloxone, and so this is less likely to be misused due to naloxone, because it really knocks, we were talking about receptors, and there's agonist type effect with heroin, for example, really attacks those receptors, produces the high that it does. Well, when you add Suboxone and which is buprenorphine and naloxone, the person won't achieve the high. They won't achieve a full high, and so it really keeps them from shooting up. So because Suboxone is that partial opioid agonist, which even takes care of the craving and withdrawal, means that it doesn't produce that high. So the full agonist, like in methadone, they really, or heroin, they get that high, and that's my point. The thing to consider, though, is that when the person if they're religiously getting Suboxone, and if they're going for surgery, it is important to, for the nurse to make sure that they tell their clinician or someone or their healthcare anesthesiologist, whomever, that they have been taking Suboxone, because they may have to do something a little bit different because they won't have good pain control with narcotics. So that's an issue to think about. We went through this. So now we're talking about barbiturates. Barbiturates are considered a central nervous system depressants. So it really depresses the central nervous system. So if we have that depressant, think about it, and the withdrawal effects, or I should say the immediate effects of that particular substance is a slowing down of responses. So they're going to have slurred speech, they're going to have motor and coordination, mood lability, the talkativeness. Think about someone now, they are less inhibited because of the effects. So it's very calming, very soothing, so they may become a little bit more talkative. Barbiturates, analytics, or sedative and hypnotics, they're in the same category. Benzodiazepine and anxiolytics are kind of used interchangeably, but what they do is increase GABA. And so in GABA, remember I said GABA is calm, so they increase calmness by depressing the central nervous system or the limbic system of the brain. So long-term use, of course, will lead to memory problems, and it can actually also suppress learning, believe it or not. I talked about, I shared that situation with 18 years starting on Xanax and been on it, and we're talking a 40-some-year-old adult and still dependent on it. So it can be a problem. So respiratory depression, you would have to think about that. Anything that depresses the central nervous system, there is a possibility of respiratory arrest, coma, and death. Barbiturates are very serious, and so most of the times that if there is an overdose of barbiturates, you're likely going to see seizure, coma, death. So if they've OD'd, this is usually the way it happens. Barbiturates, there is aggressive hemodialysis to hemodialyze the substances in the system out of the body. Otherwise, we're talking about really respiratory arrest. So it's handled a little aggressively. So chronic use, of course, will be depression and paranoia. And the withdrawal signs, think about this. And so the withdrawal for the anxiolytics or the benzos in this category are the same as with alcohol. So you're going to see nausea, vomiting, you're going to see high blood pressure, you're going to see tachycardia. Again, it was a depressant, so it was down. Now we're withdrawing from it, so our blood pressure goes up and our heart rate goes up. And so there's anxiety, depression, irritability. And this is what you kind of call, that's problematic for individuals because you call it the crashing phenomenon. And suicide is very high in this population as well. So how do you treat benzos? You really treat it with anxiolytics or anti-anxiety agents because you're going to have to put the individual that was taking the shorter acting ones, you're going to have to put them on a longer acting benzo and then wean them down from that. Neuroleptics are the antipsychotics and for symptoms of paranoia, and also anticonvulsants as well to prevent seizure activity more than anything. But it can be a powerful mood stabilizer as well. So cocaine and crack, and of course we know crack is cheaper, but cocaine passes the liver and goes directly to the brain. And so IV use is like a rush. It's like an orgasm. That's how significant it is. And so the key thing about cocaine is when smoked, it takes effect in 4 to 6 seconds. And 5 to 7 minute high follows, then deep depression. And the person who uses cocaine keeps using it maybe every 20 to 30 minutes to achieve the same high. This is why it is so, can be deadly. And I don't know if anybody remember Len Bias, but he was a basketball star, famous in his time. I think it was like 1989. He cardiac arrested on the court. And someone that has good cardiac endurance has a heart rate of 56. Well, if you use cocaine, the immediate effects is you're going to have tachycardia. With that high heart rate, then, we are talking about the possibility of the heart can't sustain a heart rate that much. And so then it's going to be death that's going to occur. So I have to keep going up, getting up because I have loud guests in the house. And they're being rowdy and having fun where I have to do this audio lecture. Don't you feel bad for me? So anyway, there's two main effects on the body as an anesthetic and a stimulant. So withdrawal symptoms include depression, paranoia, lethargy, anxiety, insomnia, nausea, vomiting, sweating, and chills, as you can read this. But I think I was talking about the cardiac arrest with limb bias before I was interrupted. But my point is that since limb bias is deaf, there have been less cardiac arrests as a result of that particular episode, because the media attention around that was pretty high at the time. And so use, of course, with cocaine, you're going to see a euphoria, anxiety, or anger. So you're going to see dilated pupils, and you're also going to see elevated blood pressure. And this thing is moving on its own. So chronic use, think about, for cocaine in particular, suicidal depression, because there is such a thing as a crashing phenomenon. The person comes down on that high, and then all of a sudden they are extremely depressed. The other thing to consider is Parladel, where you see bromocriptine. It really is because cocaine depletes the dopamine in the system. Then you have to give an anticholinergic, anticholinesterase inhibitor, anti-Parkinson's, anticholinergic agent, like bromocriptine. Is the most powerful one, potent one, that when the dopamine has been depleted, it will give more dopamine to the brain very quickly. So that's why in this particular case you would select bromocriptine. The other things that may be used is, anxiolytics, antidepressants, beta blockers. It really, so don't have to say anything about fetal addiction, because that is one of the causes. And then possible brain damage and seizures in children. Children whose mom smoked while the baby is in utero, the baby has to go through withdrawal as well. And so that's kind of what you call crack babies. So you can see seizures in infants as well. So the other thing is substance abuse of amphetamines, which you'll see dextroamphetamine. This is Adderall. It could be methamphetamine. It could be dexedrine as a stimulant used to treat ADHD, but it could be any ADHD compound. Speed, people call it ecstasy, which is a designer drug of methamphetamines. So actually, on all honesty, like some of the weight loss supplements over the counter in GNC stores have been regulated now. They were never regulated before because they had a drug like ephedra in it. And with ephedra, that was a stimulant effect, and it would increase heart rate. And so they had to remove all ephedra from Stacker 5. It was like hydroxycuts. You don't see the ephedra in it now. And some of the others on the market. And so what that does is raise your blood pressure really high. And actually I was doing this lecture, and we weren't talking about substance abuse, but I remember in Virginia as an educator teaching students like you about mental health. There was a student who had a kind of a syncopal episode. She was really sick, and we, of course, there were plenty nurses or student nurses in the room, and nurses, so we ran to get equipment. I think her heart rate had risen to 155. Her blood pressure was really extremely high. And so the paramedics actually took her out of the classroom. But she later admitted, and they kept her, she later admitted that she had taken some hydroxycuts and some Stacker 3 or whatever you call those kinds of things, but she had taken too many of those pills. And so that's what really happened to her. If you think about amphetamines, think about the immediate effects is also dilated pupils and nausea and vomiting. So, the thing that you have to be concerned about with amphetamines is because they really do deplete your dopamine. And so you have, they alter that. So the psychosis is there. And the individual becomes paranoid after chronic use. And then infectious diseases. And so withdrawal signs of amphetamines, what you call then crashing phenomenon, and there's severe depression, and suicide can result as the depression is so much worse during that phase. And so the person may be insomnic or hypersomnic, where they sleeping too much or they can't sleep at all. Oftentimes it causes psychomotor agitation. So how do you treat mainly all of these things when you're talking about whether we're talking central nervous system depressants versus central nervous system stimulants, but you do treat the underlying cause. If they are depressed, antidepressants, the thing about it is they may be on some of these medications anyway, and so it really is hard for the brain to regulate itself because they're not really sure what want it to do, which is what I say to my patients all the time. So marijuana, which is the THC, is where you can see on urine drug screens, which is a tetrahydrocannabinol. And so this is an ingredient of marijuana. And marijuana is kind of classified as a depressant and hallucinogenic type medication. And typically it is smoked, and the effects usually immediately euphoria. The person feels a sense of floating in space, and everything is slowed, and it has kind of an aphrodisiac effect, so they may increase their libido. And so there's like space, slow, perception of time, everything all right with the world. You'll see conjunctival redness most of the time. There is a heightened sensitivity to external stimuli as well. Get hungry, want to eat. And then the long-term effects, of course, is anhedonia, which is loss of interest in pleasurable activity, difficulty concentrating, and then also loss of memory. This is hallucinogens then. So hallucinogens are, drugs like LSD, PCP, most of what we talk about. Hallucinogens actually informed schizophrenia because people under the effects or the influence of hallucinogen act as if they're schizophrenic almost. And so based on this, we know that there are a number of neurotransmitters involved in schizophrenia, not just dopamine, because once the individual is under the influence, they have what you call a depersonalization. It's an out-of-body experience. There's a heightened sensitivity, and that's called synesthesia, where it's a heightened response to all of the senses, whether it's touch, whether it's smell, whether it's taste, whether it's visual. I every time I think about hallucinogens or PCP or LSD, I think about in the 60s, the hippies, and I think where they're just kind of floating, and they're rubbing each other because of the texture, and that everything's kind of like colors is heightened, psychedelic like. So if you have a picture on the wall with a lot of colors, they'll be drawn to the picture, and they'll be kind of fixated over that for a little bit. But the effects also can be, like I said, schizophrenic like, with hallucinations, and of course their pupils are dilated. Now PCP, when you think about PCP, the thing that you should watch out for individuals under the influence of PCP is they're very belligerent. They really can I hope I'm recording. They can really be belligerent and actually throw kind of a mental I remember one situation where they threw a mental health worker from one side of the room to the other. And then chronic use would be like a bad trip. And of course, there are no withdrawal symptoms that you can see in hallucinogens. I'm just making sure that I'm recording. Please let me be recording. Inhalants, we don't. I do have to say something about PC in particular, because what you have with PCP is more with chronic use. It can be like a long-lasting psychosis, resembling schizophrenia. Also, people tend to have what you call flashbacks, and so 10 years later, they may actually have an effect that was very similar to when they were, using an hallucinogen. So that's what you call bad trips or like a flashback. So inhalants, this is when we're talking about the mechanism of action is variable. So we have a lot of different things today that people are using. So the inhalants, like I said, the method of administration changes, the mode of action changes, so it's not really fully understood. But chronic use of any of the inhalants that you see here can decrease the size of the cerebral cortex. And it really does get to the brain, and it harms the central nervous system. I don't even know, I can't even think of what year it was, but it was in the late 90s where dust off, people were huffing dust off. Dust off is where you clean your computer. It has a spray on it. You can really clean your computer out. Well, this police officer's son died. He found him dead the next morning as a result of huffing, dust off. And so that got around in terms of media attention. But you have all sorts of gases. You've got nail polish, which is a remover, gives excitement. You have the nitrate poppers. You get the freon huffers, people who huffing the freon. Nitrous oxide, you know what happens when people are under the effects of that. So it goes on and on and on as different things, but you don't have to know that particular content. And then you don't have to know this particular content either, but there are the club drugs and rave and techno drugs. These are drugs that really are like ecstasy, where the people are highly sociable, they're touching each other, increases their sexual energy kind of thing. So these drugs are kind of used, and people pass them around like candy in certain clubs, and they get off on the experience. But you have to think about the kidney failure and the heart failure is a possibility. But anyway, if you hear rave or techno drugs, those are kinds of things. But there are such things as the date rape drugs, which are considered roofies, Rufinol, GHBs. But these are drugs that paralyze the individual. And so people tend to wake up not really. These are things that people slip in somebody's drink for women or men. It doesn't really matter, but oftentimes it's women and men trying to take the woman home. So they might flip them, a roofie, and next thing you know, they're waking up and they can't recall what really happened because they're really like almost like partially paralyzed, disinhibited. Remember bits and pieces of it, but not 100%. So, and this is why anterior grade amnesia is there. So, application of the nursing process. So Cage, we talked about Cage when we talked about Espert, I think, like cutting back on, drinking, annoyed, people been annoyed with you because of your drinking. How do you feel guilty? Do you have to drink more to get going again, kind of thing. And then codependency. We mentioned a little bit about codependency, but codependency is just that over responsiveness for someone else's behavior. The person becomes the ultimate caretaker. They're doing for others what they could do for themselves, and they attempt to feel good about self by fulfilling someone else's need. So those are the codependent individual. And then we have the enablers. The enablers really are the ones who are supporting or even denial the seriousness of the client's substance abuse. So we call them the rescuers and the enablers. Those are the terms that are used in the substance community. So nursing process, this is really easy. Outcome identification. You want abstinence for life. That's primary goal. And what I'm telling you right now is just the only thing you have to focus on. But you can come up with a nursing diagnosis of powerlessness or ineffective coping. You can come up with a number of things for that. So that's self-explanatory. But planning is the person has to acknowledge they have a problem. They have to set goals for themselves. When we talk about the person, I don't know why this is jumping so much. Oh, because it's like a videotape. Over a videotape that didn't work. Oh, so I gotta laugh at myself. Anyway, so stop it. So care continuum of substance abuse is detoxification, abstinence for life, stay away from slippery people, places, and things. Slippery people are those that remind them of drinking. Their drinking buddies come here. Those are slippery people. People have to actually really not return back to the community where they associate with drinking. So those are slippery people. Places are where you go, like bars that can encourage you to drink. Things that are in association with what makes you drink. So they're trained to identify those slippery people, those places, and those things. So there's all sorts of rehab, halfway houses, partial hospitalization. They have substance abuse treatment programs. So they're taught to rally around a therapeutic community. Frames is in your textbook, but that's just like feedback about risky things. It is ownership of what they're doing, and advice to change. They're giving advice. They're giving a menu of treatment options for them. And then, listening, being empathic, and that's overall for everything. And then self-efficacy and empowerment for those. But for you, the best thing is probably, remembering SBIRT, screening, brief intervention, referral to treatment for the national epidemic that we are doing now to raise awareness. And so Alcoholics Anonymous is the 12-step program. So for one to know they're powerless over their drinking, and they have to be real and honest, and they have to go through the steps. So Alateen for children, Al-Anonymous for spouses, Narcotic Anonymous, Gamblers Anonymous, those types of groups. You can read this, but just one thing that's important here is that, and anything in your testing, is that the nurse has to examine their own behavior, their feelings around dealing with addiction, because this is not an easy population to deal with. So you may have actually had someone in your family that is suffering from addiction that make it difficult for you to deal with an addicted client. But those are the things. So get in touch with that first. And of course, I do want to say the constant defense mechanisms that are used by a substance user would be projection, denial, and rationalization. They blame other people for why they drink. They find reasons. If my job wasn't so bad, I wouldn't have to drink. They don't believe they have a problem, and you can always expect, if you asked someone how much they drink or how much they smoke, they're going to underestimate the use. Always expect that. So outcomes are over time, abstinence for life. So they may get a 30-day chip and a 60-day chip, and it keeps going on. This is a big thing for people who, are substance users. So you want to decrease the denial. They need to own their behavior, improve their family relationships. So we're not going to go through the case study, of course. And I think that is it. Yay, yay, yay. Let's see. Yay for you too. So we already talked about disulfiram. So let me see where we are with this